Hi everyone. So today we are gonna start with our topic of this discussion. Yes, that is the comprehensive assessment and palpatory skills of the thoracic spine, along with the special emphasis on scapular muscles and the muscles around this chest area. Why do we need to study this topic? What is the need of studying at the thoracic spine? Yes, so today I'll be telling you why it is necessary that you should be well versed with this topic, with this region of the body, that is thoracic spine. Yes. So before talking further about this thing, I'll let you know what all we are gonna discuss. First and foremost, we'll be discussing what thoracic spine is and how it's all about, why should we study it. Second thing is we will be talking about what all muscles are there around that area with the surface marking, the surface landmarks, how to palpate them, and how to see any sort of abnormality if it is having something. Third thing, we will be looking after any red flags that can stop that you should not be doing your palpation or you should not be doing your assessment on that patient. You should refer that patient to someone else. So these are some red flag signs. Along with that, we will be discussing the palpatory skills which you need to follow. The lumbar spine palpation, thoracic spine palpation actually, and all of these things in one session. So stay tuned till the last of this session. So let's start. So first and foremost, talking about the thoracic spine. Yes, thoracic spine is also called the dorsal spine. It is composed of 12 vertebrae. So from T1 to T12. In case of if we call it dorsal spine, then it is D1 to D12. So the dorsal spine or thoracic spine is also called to have the primary curve of the body. Why? So there are two types of curve, as I mentioned in the lumbar spine palpation component discussion as well. Here as well, so what happens is when the baby is in the womb of mother, what happens? The baby is always in for 9 months. The baby is in the curved position, forward bent position. So that leads to kyphosis as the main curve that is present. So that is the primary curve. And the secondary curves are the cervical and the lumbar lordosis. So that develops after birth. So that is why they are called secondary and this one is the primary. So the primary curve that is present before the birth is there in the thoracic spine, that is the kyphotic curve. Now what happens is, why do we need to study thoracic spine? Yes. So if we see the structure of the spinal cord that goes from midbrain to pons to medulla oblongata and then down to the spine, what happens is the majority of the spinal cord lies from the T1 to T12 because at L1 the spinal cord ends. So L1 is the ending. So the spinal cord ends at the L1 vertebrae, and then after you have the chorda equina and the nerve roots and branches that go down. So it is not the complete spinal cord that goes down. So it ends at L1. So that means just above L1 you have T12. So T1 to T12 is the maximum, the longest area which has the maximum part of spinal cord. So that is why it becomes a very important area to discuss and to work upon. You should be well versed with this area and you should be knowing everything about it. Yes. So for that part, talking about the basic structure of thoracic spine. In thoracic spine, we do have something called, like in every other part of the body, vertebrae. We have in thoracic spine as well the front vertebral body, the back spinous processes. In between the two, we have something called the neural arch, that is maintained by the front pedicles and the back ones lamina. So vertebral body along with the pedicles and lamina go back and form the spinous processes. If we see on both the sides of the vertebrae, we have two projections called the transverse processes. So now these vertebral body have something called demi-facets on both the sides too. So this is the special feature of thoracic spine, which others do not have, because others do not have ribs. So yes, in thoracic spine you have ribs, so that is why to connect them, they have something called the demi-facets on both the sides. Demi means sort of half, hemi-facets or demi-facets, right? So they connect to the demi-facets and go to the front, and yes. So that is why the ramifications are present there. Along with that, you have something called the facet joints. So that is also present in the lumbar spine as well. So in that one, what happens is the superior articular surface of the inferior vertebrae and the inferior articular surface of the superior vertebrae, they connect together to make the facet joints of the thoracic spine. Now, when we talk about thoracic spine, what all things do we need to take care of? Yes. So first and foremost, the major thing when assessing a patient with thoracic spine pathology is a red flag. Yes. What all red flags can you see in a patient with thoracic spine pathology? So if a patient presents to you and he or she complains that he has a pain in the thoracic spine, so you should be taking care of the red flags. So now what are red flags? Red flags are those signs which are present in a patient which can mimic normal symptoms, which can mimic as if they are normal musculoskeletal conditions, but when assessed in detail, they denote some serious pathology in the body. So there are some systemic issues that needs to be taken care of by the specialty who are specialized in that particular care, like cancer, metastasis, fracture, all these things come under red flags. So we have three types of flags: red flags, yellow flags, and the normal patient then come to you. Okay, so red flags are, so let's say talking about the history taking of a patient with thoracic spine pathology, the patient comes to you. First and foremost thing, you ask about the name, age, gender, and everything. Name for identification, that who the patient was. Age, yes, age is a major factor, because after the age of 55, the chances of cancer increases, the chances of having osteoporotic fracture increases. So these all are red flags. So if a patient presents to you with a pain in the thoracic spine and he says that yes, I am 58 years old, so you should be having some triggering factor in your mind. Okay, he is 58, that means more than 55. Okay, that might be a red flag. I need to assess further. So yes, a pain. Now the second thing is gender. Yes, so gender component, like let's say in males you have more of prostate cancer and in females more of a breast cancer. So the area, the chest and the thoracic spine is involved in that. So that is why it should be taken care of properly. The gender also plays a big role. Third thing is thoracic spine in itself is a major issue. Like this structure is the one that has the highest chances of getting a metastatic cancer. So getting a metastasis is the highest chance in a thoracic spine pathology. Along with that, if a patient presents to you, let's say with some fracture which you are not able to diagnose, or so that is why we need to take care of these red flags. So these are the red flags. Now coming to what all structures are there in the front and back of the thoracic spine, and what all you need to take care of. What all muscles are there which you should be taking care of. So before moving on to the structure of all these muscles, I would like to ask, like, how much movement is present at the thoracic spine, or else the other way around, what all movements are present at the thoracic spine? Yes, I want this answer from you people because it's a very basic question. So what all movements does the thoracic spine permits? Is it flexion or is it extension or what? Yeah, I'm waiting for your answers. Yes. Yeah, perfect. Good. Yeah. Perfect. Going great. Yeah. Awesome. So you people just answered that very nicely. Yes. So now, because movement is very limited, it is very less in thoracic spine. Why? Because as I told you, the spinal cord is there. The body doesn't want to injure that, so that is why it has reduced its mobility to serve the function of stability. Alongside, there are some visceral organs, thus major motor component, your heart all the time it's working. So this is a visceral organ. Your lungs, these are visceral organs, they can get damaged easily. So to protect them from further injury, the thoracic spine has very limited mobility. It has restricted itself to help out these structures to survive properly and to help our body. So now we'll be coming to the muscles that are present in the thoracic spine. Yes, for the muscle component, I would like to call our model for today. Yes. Alright, so talking about the muscles of the thoracic spine and the scapular area. So we'll be discussing first the muscles and then the thoracic bones and spine component all together. So first and foremost, the muscles of the thoracic spine. So the major muscles, the superficial muscles first, followed by the deep muscles. So first and foremost, the muscle is upper trapezius. It starts from the occipital protuberance, nuchal line, and then goes towards the acromion process. So here's the acromion process, the tip of the shoulder. It goes like this, and then from the acromion process, it covers the spine of the scapula and then goes down. So this part we call it upper trapezius because it is upper. Then it goes medially from the scapula medially towards the spine. So it is called the mid trapezius, and then it inserts down at the T12, right? So it extends up to a T12. So this is called the lower trapezius. So to check the function of this particular muscle, what you need to do is first and foremost for the upper, then mid, then lower trapezius. For the upper trapezius, tell the person to elevate his shoulders up and see. So here's the upper trapezius, okay, and down. Now for the middle trapezius, so these fibers are aligned like this and this. So they'll pull it like this, okay. Take it back, retract the shoulder, and you can see the middle trapezius. Now relax. If we want to see the structure or the palpate the lower trapezius, take both the arms back and retract the shoulders, and we can easily demarcate. Yes, here is the lower trapezius that is working. Okay, so these positions are there for assessing the to palpate the upper, middle, lower trapezius. Now the next muscle for the thoracic part, we have the muscle called Latissimus Dorsi, the biggest muscle of upper and lower back. So this muscle starts from the ilium, it goes up like this, covers this complete area, and then it coils inwards and inserts into the shoulder region, okay, into the humerus. Now this muscle, how can you palpate this muscle? Just tell the person to extend his shoulder. Okay, take it back, take it back. Okay, right now you can easily see here is the demarcation. So that is why we call it the wings. So the Latissimus dorsi is called the wings. So these are wings of the patient, right? So Latissimus dorsi muscle, you extend the shoulder back and you can easily demarcate it completely along its route. Okay. Third muscle is, so this is the upper diamond shape. We call it diamond shape, the trapezius. We call that, okay, it is a diamond shape muscle. Actually, it is not diamond shaped, right? So what happens is it comes and then it turns inside rather than going like this. It's not completely covering this area. It's turned inside and then goes down, right? Now if we take off both the trapezius up and if we open it up, we will see that there are two more muscles present here. Actually there are many, but yes, we'll go layer by layer. So yes, the next layer of muscles is rhomboids. So we have the muscles called rhomboid minor and rhomboid major. Rhomboid minor starts from the C7 and ends up at T1. And from T1 to T5 we have the rhomboid major. They attach on the other end to the scapula superior border, right? Superior angle of the scapula, they attach to this part. And how can you assess them? Just tell the patient to retract the shoulders and yes, here you are. So these are the rhomboids, okay? Yeah, relax. Along with that, you have a muscle called this one. This goes from the superior angle to the mastoid and the posterior protuberance. So this muscle, the levator scapulae, so it helps to levator, as the name says, elevates. So it elevates the scapula up, and so along with the upper trapezius, it helps to elevate the scapula up. So the medial border of scapula will go up with this muscle. That is why it's called levator scapulae. Relax. So these muscles are the major muscles which you need to see in a patient with, thoracic spine issue. Alongside, you have some other muscles as well. As you can see here, you have this muscle called supraspinatus, right? In supraspinatus, what happens is it starts from the supraspinous fossa of the scapula and goes up towards the greater tubercle of the humerus. Likewise, you have the intraspinatal muscle that goes from the intraspinous fossa of scapula to the greater tubercle of humerus. So this scapula, how to demarcate it? For scapula thing, what you need to see is, so in center you have the thoracic spine. On the sides of the thoracic spine, what you need to see? Yes, you have something called this. See, so you move from the center to the sides. The first palpable portion is the medial border of scapula. Okay, from medial border you go down and you palpate the lowermost bony area, that is the inferior angle of scapula. So here mark the inferior angle, and then you make a V-shaped structure from your thumb and finger and make it like this. So here you grab the scapula completely, and here is the lateral border of scapula. And last but not the least is the upper or superior border of scapula along with the superior angle, the edge of the corner of the scapula. So these structures you should be well versed. Why? Because they give you a rough idea. Like let's say if you come down from down to up and you come till the lower inferior angle of scapula, you can easily touch here. Okay, this is the inferior angle because it directly correlates with T7. So here is the T7 vertebrae. Okay. Likewise, if you know where the superior angle is, so you can easily demarcate. Okay, it is the T1. Okay. So if you are you are able to palpate the structure of the scapula, you can demarcate the thoracic spine structures as well alongside. Last but not the least, this spine of scapula, that is just so from the superior border you move a bit down and you can palpate. Yes, here is a line going from medial part of scapula to the lateral part. So this complete line is called the spine of scapula. It corresponds to the T3 vertebrae of the scapula. So that is why we need to be well versed with this structure of the scapula and the muscles around it to palpate the thoracic vertebrae. We'll be discussing this in detail. Before that, we need to discuss the muscles of the front part of the chest as well. For that, you need to turn around and yes. So here on the front part, we have many muscles, but yes, two are important for the thoracic spine structural component. We have first and foremost some bones. So we have the sternum, we have the clavicle, two clavicles, one sternum. Sternum has three parts: the manubrium, the body of the sternum, and the xiphisternum. Right? So three parts. So manubrium and the body of the sternum has in between this joint called the manubriosternal joint, and this angle. So what it is like this. So upwards it's manubrium, downward it's sternum. Body of sternum. So it is a bit angled. So this angle is called manubriosternal angle or angle of Lewis. So why are we so much reluctant to learn this particular angle of Lewis? Because this is of quite importance to us. This helps us demarcate the L4, L5 disc level on the back side, on the posterior aspect. So this directly correlates with the posterior L4, L5 disc level. That is why we should be well versed with where the manubriosternal angle is. So first and foremost, you need to just see here. So it is a jugular notch. So the surface So you first and foremost, before moving further, just touch your own jugular notch. So I have this packed suit, I can't just touch my jugular notch, but you can. So just put your finger at the jugular notch, don't press it too hard. It can injure your internal vessels that are passing behind it. So just touch it and feel it, right? It's a concave surface. Then you move down and you can feel something, some projection, a bit of uplifted area. So this is the angle of Lewis. And then you go down and here you can palpate a pointed region, that is a xiphisternum. Never ever palpate your patient's body or his structures with your thumb, not like this. Okay, I'll just press and I'll make a hole in his body. No, the patient will never come to you again if you do it that way, right? So you should be using your fingers and the pulp of the fingers. So this way, and smooth, easy, right? The patient should not feel the pain because of your palpation. It should not be like that you are asking, are you getting the pain? He says no. Are you getting the pain? Pain. Not that way, right? So it should be gentle, smooth, and yes, at the same time, that much tender to handle it with care. Alongside, we have the pectoralis muscle here. So this is the complete pectoralis major muscle from the sternum, and it goes up like this and ends up on the humerus, right? So you can easily demarcate the pectoralis major. Now, to palpate the pectoralis major, you have three actions. Either you flex the humerus, or you internally rotate the humerus, or adduct the humerus, right? So for that thing, like let's say if you are doing it this way, so either you take it forward, okay, and hold it. So in this one, the major action will be of deltoid, but yes, this is also acting. So yes, take it up and see, you can easily demarcate, yes, humerus is acting. Likewise, if you tell the patient to internally rotate the shoulder, yeah, take it in, and you can see the pectoralis major, right? Last but not the least, if you tell the patient to adduct his shoulder, take it down from the humerus, yeah, and yes. So see, you can easily see this is the complete pectoralis major. Now there is another muscle, the pectoralis minor, and you should be also be knowing how to palpate this one, because majority of times you have this muscle that is tight, that is compressing the internal structures, and that leads to in fact anterior tipping of scapula. So what happens is the scapula turn. So when the scapula ends up here into the acromion, so this is the acromion process, right? Alongside, what we have is from the scapula comes another structure called the coracoid process. So the coracoid process, how to palpate the coracoid process? So here is the scapula, backside, and here is the clavicle. So the clavicles, you have the medial convex part, then the lateral concave part. So this concave part, yes, you also should be palpating with me your own, coracoid process. So move laterally towards the concave part and then dig a bit down and in, and you will find, yes, here is the coracoid process. So from the medial to lateral, as soon as you hit the concave part of the clavicle, you go a bit down and in, and yeah, here is the coracoid process. And the pectoralis minor originates from the ribs, third, fourth, and fifth rib. So like this, three fibers going like this and originate and goes to the coracoid process, inserts here. So this is the structure, okay. Now if you want to mark out which one is the pectoralis major and which one is the pectoralis minor, so what you need to do is your fingers and thumb, okay, go a bit deep and yeah, so here, and go a bit deep and in, and yeah, so here is the complete muscle pectoralis major, right? So I have his pectoralis major in my hand completely, and if I need to see how much fat or skin is there, so I'll just take it up like this. So it's very paper thin skin, he gyms a lot. Along with that, the pectoralis minor. Pectoralis minor component is, so what you need to do is, if you go like this, you will be palpating the pectoralis major. So what you need to do is make the patient take the hand back and keep it lifted. So this way the scapula goes into downward rotation and adduction. So what happens is, this is a bit forward, so the coracoid is a bit forward, so that leads to relaxation of this muscle, and then you can easily go again the same way. The anterior concave part of the clavicle, go a bit deep and in and palpate the coracoid process, and then here's your first slip of pectoralis minor, then you go down and here's your second slip of pectoralis minor, and you go down and here's your third slip of pectoralis minor. So this is the way you need to palpate the pectoralis minor muscle. Okay, so these were the muscles we need to be much cautious about. And last but not the least, yes, we have something called Serratus Anterior, and I had demarcation for that. Yes, it's on this side. Actually we have on both the sides, but yes, I have demarcated on this side, so I'll show you this side. Yeah, this one. So take your hand a bit forward, like the push, the punch position. So this is also called the punching muscle, the serratus anterior. So here is the serratus anterior. It comes from the anterior surface, medial border of the scapula. So it comes from inside and goes out laterally like this, and here it ends up here. So this is the serratus anterior. Now, because we have a serratus anterior, we should be having a serratus posterior as well. Okay. So where is the serratus posterior? Serratus posterior, obviously it will be on the posterior side. So there is nothing new in that. But yes, there are two serratus posteriors. So one is serratus posterior superior and one is serratus posterior inferior. The serratus posterior superior elevates the scapula up. The serratus posterior inferior depresses the scapula down. So that is what you need to be very much cautious about. You should be knowing that thing, that here is the serratus posterior superior. Here is the serratus posterior inferior. Okay. Yeah. So these were the muscles that are of major concern in the thoracic area, and you should be knowing them. Now let's move on to the palpation of the thoracic spine. So first and foremost, whenever you palpate the thoracic spine, first thing is that it should be done in standing. Why? Because in standing, all the muscles we discussed are actually working. So you can get to know that which all muscles are working, what all issues is the patient facing because of the active muscle contraction. Because gravity is all the time pulling him down. Okay, gravity is pulling him down. His muscles are working. They are not allowing him to go down. So that is why we should see in standing only that how the things are going, right? So in standing, first and foremost, you will see the upper trapezius bulk. You see on both the sides, you can mark out, okay. So what all things are you gonna see in a muscle? The tone of the muscle, any pain on palpation, and the structure, visible, changes. So if I see, you can make out this trapezius is a bit big, and this one is a bit lower down, right? If I palpate the muscles, I can make out this is a bit overactive, this is a bit floppy, a bit underactive, so working less. Likewise here as well. Okay, yeah, so here also the muscles are a bit floppy, but on this side, let me check. Yes, as per my what I was presuming, yes, it is there. So this side is more overactive. Why? Because I presume you are right dominant, na? Yes. So he is right dominant. So presumably in right dominant persons, the right side muscles are a bit overactive if they are not taking care of proper muscle activation. So there is a bit of muscle, more strength on the right, and they are more overactive, and the left is lesser active or underactive. So along with that, we will see the distance of both the scapula from the midline. So yes, here is 3 fingers and here it's 3 fingers. Alright, perfect. Third thing is we will see the inferior angles and inferior angles. So on both the sides they are similar, perfect. Both the acromion processes at same level, perfect. Then both the ilium should be at the same level. Along with that, you should be palpating the muscles with 2 fingers to see if there is any pain along the course of the muscle. So anyhow along the root, where the muscle starts and where the muscle ends, if the person is having any pain, that might be a reason, that might be a caused because of some issue in the spine, in the thoracic spine. And if alongside you need to see the structures of the thorax as well, the thoracic spine actually. So you'll see from top to bottom like this, you'll go and you'll see if there is some rotation of the spine. So likewise from sliding from top to bottom, you'll see for any spine rotations. If it is there, it might indicate scoliosis or muscle overactivity. So if I assess him right now, let me check. Yeah, so he's perfect. Okay, here I can mark out that there is a bit of right side rotation. Actually it's left rotation of the front part of the vertebrae. So let's say it is a vertebrae. Here is the spinous process. Now it is rotated like this. Okay, so what happens is the front part will go towards the left and this is going towards the right. So this is a bit of rotation on this side, presumably because of these muscles are overactive, so they are pulling it towards this side. So like this, these muscles are pulling it towards this, that is why it's going like towards the left side. Okay, along with that, last but not the least, you have the Quadratus lumborum muscle, the place where the ribs end. So here is the end of the rib. At this part and from here to mid, the midpoint of this. So the midpoint of half of the back, so almost at this point, and the place where rib ends, the 12th rib. So you come down and it is the mid center. Here is the Quadratus lumborum muscle. You need to palpate it. You need to see if it is if there is any pain or tenderness present on palpation. So these things you need to be check while a person is standing and you are assessing the person is standing. Now let's come to what all things we need to perform while the person lies down on his stomach. So we'll be assessing the person in prone position. So let's start with the palpation of a patient in prone. So how to palpate the dorsal spine or the thoracic spine. So for palpating the thoracic spine, as I told you, there are T1 to T12, 12 vertebrae. So you should be, either you can progress from down to up or up to down, right? So from T1 to T12 or T12 to T1. So I'll tell you both the ways on how to go from T1 to T12 or T12 to T1, right? So let's first start with the upside down approach. So in upside down approach, the patient will be lying in prone position. We'll tell the person, so we know that whensoever the person extends the spine up, like cervical spine, if I tell the person to take it up and down, yes, okay. So in this thing, I got to know that this is the C6 vertebrae. So the speciality of C6 vertebrae is that with extension of the spine, it goes in, it digs in, and with flexion, normal movement, then it comes out. Now I go a bit more down, again take it up. Now he did extension, but still I can palpate the spinal process. That means it is C7, the most palpable vertebrae. Again I have T1. So next vertebrae after C7 is T1. Okay. So T1 I'll mark it here. Okay. Yeah. So here is the T1. Okay. Now coming down to, so from T1 I'll just feel that here is a blank gap. So below this gap is this next spinal process of T2. Okay. So here is the 1 and there is a 2, right? T2. Now just below T2 again you have a gap, then spinal process of T3. So here is the T3 spinal process. Okay. Then again you go down and you feel a gap here and then a spinal process here. So you will mark it as T4. Okay. Likewise, you keep on going down, you keep on palpating the gap and then the bone next to it, and then you can mark out that's T5. And yes, likewise, so I need to sharpen up my marker, because it's always said that you sharpen up your X before going for a hunt. So I sharpened it up, but yes, these are technical issues. So this is T5, right? Again this gap, and then we have T6, and again this gap in between, and here we have T7. Okay, now you can see one thing. We are always taught that it is the inferior angle of scapula that aligns with the T7. In his case, it held true. So yes, this might form a basis that yes, if you want to demarcate T7, you can go at the inferior angle of scapula and come medially, then you will find T7 here. Second thing, the second thing is, this is the spine of scapula. This one is the spine of scapula. Now the spine of scapula, if you make a straight line from here, you can see this vertebrae is T3. Okay, so T3 aligns with the spine of scapula. So that is why I told you that if you are able to palpate the scapula, you can palpate the thoracic spine very easily, right? So this is a T3, and likewise here the superior angle of scapula, it's a bit because of this thing. So the superior angle of scapula, if we draw a straight line from here, you can easily see it is the T1 spinal process. So T1 corresponds to the superior angle of scapula, T3 corresponds to the spine of scapula, and T7 corresponds to the inferior angle of scapula. Now comes T8. Okay, afterwards we have T8 here. Then we go down and yes, we have T9 here. Okay, then and here we have. Okay, one more thing you should be cautious about, you should not moving the skin like this, because if I take it up, so the skin is mobile structure. So if it goes up, the bone will remain here only, but yes, you will mark it here, and when you leave it, it will go down. So you should be cautious about that thing. So here is the T7, then T8, then T9. In between there is a gap, and then we have T10 spinal process, right? Again this gap, and T11, and then we have this one called T12, right? Okay, so this is corresponding to T12. Now I want to confirm that the markings I did are correct. How can I confirm that thing? I should be having some verification tool with me. I should know that this is the correct marking which I did. So for that thing, what I'll do is I'll just see the ribs. So the ribs correspond to the level of vertebrae. So if we see there are 12 rib pairs on each side. So on this side, if I see where does the rib ends. So this is the 12th rib. It ends here. Okay, you will not be going deep down like this. It can cause damage to the kidneys of the patient, or can irritate the Quadratus Lumborum muscle that is present here. So you should be going gently like this. You will be palpating this like this. Okay, here is the T12. It goes up like this and ends up here. So this is the T12. The rib is going like this. Okay, and it attaches on the T12 vertebrae. So here is the rib on this side, and it may cause tingling to our subject. Okay, so you should also be, it is verified that yes, because both the 12th ribs are attaching to this part, so it is the 12th T12 vertebrae. So now the other way round, as I told you that I will be telling you both the ways round, going down to up and up to down. Okay, so if we go T12 to T1 the other way round, so we will be first palpating the ribs. Okay, both the sides, ribs attached to a common vertebrae, mark that out as T12, then gap T11, gap T10, gap T9, gap T8, likewise up, and here is the T1. Now again you will be verifying your thing, that are you going correct, are you marking correct or not, by looking at is the T7 corresponding to the inferior angle of scapula, is the T3 corresponding to the spinal scapula, is T1 corresponding to the superior angle of scapula. But yes, there might sometimes be a discrepancy in this correspondence because every patient has different body structures. The anthropometry of every person is different. The size of scapula may also be small in some patients. In some it may be a more bigger scapula, right? So it is a bit vague, but yes, the central component which I described you, that the vertebrae, then gap, then vertebrae, you palpate it. I would rather suggest just after completing this discussion, you go with some of your family member or your friends with you, you palpate this thing. So once you keep your finger on a vertebrae, spinous process, and you feel a bit down from it, you'll see that there is a gap there. Okay, so that is the intervertebral gap, interspinous process gap, right? So there is a supraspinatus ligament that crosses over and over that thing. Okay, now so this was about the central spinous processes. Along with this thing, we have something called the transverse processes as well. So let's say if this is the vertebrae and this is the, so this is the body of the vertebrae like this is the spinous process, and this is the transverse process. So a transverse process doesn't like this, it is not lying like this, it is like this. So if the spinous process is projecting backwards like this, transverse process goes a bit up. Okay, so that means, what I mean by that, so let's say if it is T5 vertebrae, the spinous process of T5 would be somewhere around this, like this and like this. Okay, so here are the transverse processes. So the spinal process lies at this level, but the transverse process lies at this level. So why is this thing there, and how to palpate the transverse processes then? So you should be knowing which transverse process you are touching and how can you get to know that thing. So for that thing, the rule of thumb is for T1, T2, T3, you add one finger distance and you have the spinous transverse processes. So for T1, keep, so this is the spinal process, keep one finger here, just one finger up, and here is the spinous transverse processes of the T1 vertebrae. They they are like this. Okay. For T2 as well, spinal process is here. So go one finger up and you have your this transverse process lies a bit up. So it is lying here. So that means, what can you mark out? Again, let me mark 2-3 transverse processes for you so that you can demarcate it. So let's say it is the T7 vertebrae. Now what happens is, till T3 you need to add one finger. Okay, just one finger from here and one finger up. Okay, from T4 to T7 you need to add two fingers. What do I mean by two fingers? So from the vertebrae you need to mark two fingers up, and now you are marking it like this. Okay, so from the spinous process of T5 you mark two fingers up and you found that yes, here is the transverse process of T5, so lying that much up. So if you want to mobilize the transfer process of T5, you will not be mobilizing it here or here. You will be mobilizing it 2 fingers up. So that means you will apply the force here and the movement will happen here. Okay. So that is why we should be knowing where the transfer process is. Now from T8 to T9, you have to add 3 fingers. Okay. So 3 fingers means, so this is T8, the spinous process of T8. You place 3 fingers up and then you mark it here and you mark it here. So that means the spinal process of T8 would be lying like so here is the spinal process of T8 and here are the transverse processes of T8. Okay, so lying in such a manner that you have to palpate them here instead of here. And likewise, so this is T8 and T9. Now T10, T11 and then T12. So it is plus 2 and plus 1. So now plus 1 means from T12 you need to apply just 1 finger up and here is your transverse process. Okay, so you can palpate the transverse process here. So here is the transverse process. If you need to mobilize the transverse process of T12, just place your pisiform here and press it down, you can mobilize it. So this was about the palpation of the transverse processes and the spinous processes. Now along with this thing you also have something called the ribs. So how to palpate the ribs? So this and this are the 12th rib. Likewise you have 11, 10, 9, 8, 7, right? So if you go from here, so you need to choose the mid of the rib, right? So first from this thoracic spine to the lateralmost corner. So this portion you need to choose the mid of it. So here is the mid. Now this mid portion is where you will palpate the ribs. So here is the 12th rib. Then you move up, you will find a space here, and then here is the 11th rib. Then here is the 10th rib. Then here is the 9th rib. So that way you will leave a bit of space in between, and then you have the ribs there. What and why you need to palpate these ribs and these transfer processes? So what happens is, like let's say if I want to check the joint play of thoracic spine of this individual, for the so we have 2 criteria, 2 ways to check it. Either we can give a central anteroposterior pressure. Central means in the center, anteroposterior means anterior to posterior, or here PA pressure, posterior to anterior, right? So because we are on the posterior aspect of the patient, so what we will be doing is we will be giving a posterior anterior pressure on the central part, that is the spinous process. So for that thing what we need to do is we need to use our pisiform bone. So if you need to demarcate your pisiform, so here is your hand and this projection on the medial side is the pisiform, right? So you can demarcate it like this. Okay, here is your pisiform bone. What you need to do is keep your pisiform like karate. Yes, I'll break it. Okay, and yeah, I kept my pisiform on the spinous process of T6. Okay, now because the spinal processes are aligned inferiorly, so the superior spinal process, if you will see, it is at the back of the vertebrae. Then you go down, it was spinal process is projecting like this like this. Okay, so it's projecting downwards then upwards, right? So if talking about T6, so T6 has a orientation of almost around 45 degrees. I'll be placing my hand like this, then open it up as I explained to you last time as well. Keep your hand here, keep your hands relaxed, and then push it down. Okay, 1, 2, 3, 4, 5. So I just assessed how's the joint play. So I found it good that this bone is being mobilized properly. It has a nice joint play. Neither has it got hypermobility or hypomobility. Likewise, I'll assess at one more point, that let's say at T11. So T11, I'll place my pisiform, again the same position, opening it up like this, place it like this, and body weight, and yes, assessing the T11. So I found again here as well the joint play is normal. Joint play means the movement that the joint is permitting, that is required for normal joint movements, right? Along with that, so this was the central PA pressure. Now we have something called the unilateral PA pressure. Unilateral means one side. So now let's say if I want to mobilize the transverse process of a particular vertebrae, I'll be going to one side and giving a unilateral pressure. And how can I give a unilateral pressure? First and foremost, now we know very well that let's say if this is the T9 vertebrae, so this is the T7, T8, T9. So I need to mobilize the transverse process of T9. So now for T9 the criteria is 3 fingers above. So T9 is here. Yeah, I palpated that here is the spinal process of T9. I moved 3 fingers up. Here would be the transverse process of T9. Now I want to confirm that is the transverse process actually present here is for T9 or some other bone. So what I'll do, I'll place my one thumb at T9, and then I'll just push this one, the transverse process which I marked by 3 finger calculation. I'll just push it down, and I'll see if the movement is happening at this spinal process or not. If moving this posterior anteriorly causes movement at this part, this spinal process as well, so that means we are at the right transverse process. Okay, so what we'll do is we'll keep our hand like this, pisiform on this transverse process, and then again the same, this and placing it like this, and then pressing it down, and 1, 2, 3, 4, 5. So generally in 3 to 5 movements, you get to know that how the joint play is. The joint play normal, hypermobile or hypomobile. So that way you can decide further treatment for this part. And so these were the considerations you should be well aware of. Last but not the least, so this was about the central PA pressure, unilateral PA pressure. Now we have something called the rib springing. Okay, so let's say here's the T10 rib. I want to mobilize the T10 rib. Okay, so first and foremost what I can do is I can go at T10 vertebrae, spinal process, and then palpate the rib like this. If I'll press very tightly or deeply, it may cause pain to the patient. Okay, so we should be very much light and gentle in this thing. So here's the T12, here's the T11, and yes, here's the T10 vertebrae. So T10 rib corresponding to T10 vertebrae. Okay, now what I'll do is I'll place my hand here. Okay, and again the same thing, open it up and then press it down. So this way I am mobilizing the rib or rib springing. This way I am assessing whether there is some issue with the rib. There might be some fracture, some contusion, some punch hit or something at the rib that might be leading to this pain. Okay. Alongside we will be assessing that now we mark there is a spinal process, this, all the spinal processes are in line. You can see that T3 is just a bit to the right side that I marked in the very beginning when he was standing, that it is a bit rotated, right? So that is why it is a bit to the right. Otherwise the spine is in normal straight alignment. If the patient has curved alignment, that means he might be having scoliosis. Alongside, what you can see is, let's say if your patient, the history of the patient, the occupation the patient has. So let's say if this patient might have got something to do with IT professional who is working on 2 laptops in one go. So he has to rotate first to the left, then to the right, then left, then right, all the way around. The complete day he spends like this only, turning to the left and right side just to see what is there in the display. So that way that person might get injured. That might lead to rotation issue and pathology at the thoracic spine. Alongside, if you are from a sports background, if you are a sports physio, and you might be dealing with hockey players or golf players. So in those people, what happens is, because the shots are like turning and rotation, so that leads to problems and pathology at the thoracic spine as well, because of the continued and sustained repeated rotations that happen at the thoracic and lumbar spine. So these things should be taken care of every time you see any patient. And first and foremost, rule out the red flags, then palpate the structures, see if there is some pathology with any part of the structure that is we are assessing. Check the joint play, check the end feel of the joint, and check for tenderness on palpation, and that's it. And you have many components of assessment, right? So all those needs to be taken care of. So this was all about palpation, what you need to take care of. Yes. So, alright, yeah. Now, I believe after this overwhelming discussion with you all on this topic of lumbar and thoracic spine palpation and the muscular structural landmarks as well, I feel all of you are now well confident about all these structures which all are present anywhere around the thoracic spine and chest, and you will be able to demarcate them whenever you see them without any issue and with utmost ease. With these words, and along with reminding you again of the red flags, that you should be taking care of all those as well. The red flags are of utmost importance. So I will brief myself here because it is a short session, but yes, we'll be coming up with this sort of sessions in future as well. So every Thursday we conduct these sort of sessions for you people only. So stay connected, stay safe. So I'll be looking forward to receiving more overwhelming responses from your side. If you feel that you want any topic to be covered in the near future and you want that we should take up discussion on that as well, let us know in the comment section. We'll be waiting for that. Take care. God bless you.